Welcome back to Mayo Clinic Cardiovascular Podcast Series, Interviews with the Expert. I'm your host, Sharon Hayes. I'm a non-invasive cardiologist and vice chair of faculty development and academic advancement for the Department of Cardiovascular Medicine here in Rochester, Minnesota. Today, I'm joined by Dr. Juan Crestinello and Melissa Erdman. Juan is professor of surgery and chair of the Department of Cardiovascular Surgery, where he specializes in valvular and pericardial diseases here at Mayo Clinic in Rochester. Melissa is an instructor in surgery, a physician assistant in cardiovascular surgery with expertise in aortic and valvular surgical patients. Today, our topic is the management of postoperative pericarditis. So postoperative pericarditis is far less common than it was several decades ago when I first started practicing, but it can still be a really vexing problem that can cause patients considerable morbidity today. We'll be talking and discussing on how to diagnose and manage postoperative pericarditis, as well as discussing operative and non-operative measures to prevent or reduce the severity of pericarditis after cardiac operations. So welcome, Juan and Melissa.
Thank you.
So first, tell us a little bit about how big of a problem this is for patients and for you in your practice.
Well, thank you, Dr. Hayes. Thank you for having us to talk about this relatively common problem. Mostly you see these patients that a few weeks after being discharged from the hospital present with symptoms of fevers, pain, which is usually a type of pleuritic pain, or it can be like a stabbing pain, and elevated inflammatory markers. And that's something that it can be protracted and slow down the recovery of the patients. In terms of the incidence of the post-pericardectomy syndrome, it varies depending on the series, but I would say that it ranges between 1 and 40%. However, in our practice, we see it probably in around 5 to 10% of the patients. But certainly for those who have it, it can be a serious problem that compromise the recovery after surgery.
So how is postoperative pericarditis different from pericarditis from other causes? I practice in the pericardial disease clinic here, as you know, and what is your perspective? Obviously, the injury to the pericardium is different, but tell us how we should be thinking about this type of pericarditis differently.
It's different in the obvious way. It's in that we know what the cause is. It's that initial trauma or injury to the heart of the pericardium with the surgery itself, versus the other types of pericarditis that are often unknown in cause or suspected viral in nature. The importance, or the other big difference, is that we have an opportunity, rather, to treat right away and prevent the downstream complications versus other kinds. When we talk about trying to figure out a differential diagnosis, it may take longer to figure out what's wrong with the patient. With this, we know right away, patient just had surgery, pericardium is injured, they've got the classic symptoms that Dr. Crestinello just mentioned, and we can jump in with the treatment much faster and prevent those downstream complications.
So how do you preemptively, what do you do when you've got a patient, they come back a week or two? What are the strategies you're using to treat these patients? Do you need to do any diagnosis, or do you assume if they've got elevated inflammatory markers? So I know you see a lot of these folks in the early and mid postoperative patients. So what's your approach to that?
Yeah, it's a very interesting question because, as you know, our patients, a small percentage are local, but we have a lot of patients that come from all over the nation or the world. And so often I'm talking to them on the phone when they're telling me a week to 2 weeks out that all of a sudden their pain is much worse than it was. They try and lay down to go to sleep and it's worse. They've developed a new fever, these sorts of things. And so something that I would do in the office, like check inflammatory markers like a CRP, check a chest x-ray, check an EKG, perhaps an echo later down the line. I don't always have the ability to do those quickly right here in Rochester because they're not here. And so I work with their either primary care family practice type provider or their cardiologist to do those types of diagnostic tests. Although I will say that sometimes they just start having these symptoms, and I can jump on it right away with treatments that we can talk about a little bit. And we don't, if they respond right away, we don't necessarily have to do a lot of diagnostic testing. We can just go ahead and treat.
Empirically.
Correct.
So what do you treat them with?
Yeah. Well, the mainstay, the cornerstone of treatment still is NSAIDs and colchicine. Colchicine, we usually dose twice a day, and typically anywhere from 6 weeks to 3 months. I know, Juan, in your practice and for most of the surgeons, if it's something we're catching, not necessarily with symptoms, but on, for example, echocardiograms after surgery, if we see any evidence of constriction, we'll start right away with the colchicine. For sure, plus or minus the ibuprofen, depending on the type of surgery and if they have symptoms such as pain or EKG changes. Shorter course of 6 weeks, maybe with just some evidence on an echocardiogram versus 3 months if they've got fevers and a lot of pain, that sort of thing. NSAIDs, along with the colchicine, is typically ibuprofen. You know, ibuprofen's cheap. It's over the counter. It's great. And we typically use that for 1 to 2 weeks until their symptoms resolve. And then we'll try and do a slow taper off of the ibuprofen. You can also use indomethacin. I tend to use that if ibuprofen doesn't seem to be working. And there's aspirin as well. We typically don't use aspirin unless the patient's had a recent MI and other NSAIDs are contraindicated. Then corticosteroids are not first-line therapy, but can be used for relapsing types of situations where the pericarditis doesn't seem to want to go away.
I was just going to ask for the ibuprofen and the medicine. I'm assuming you use that scheduled, correct, and at high
Correct.
dose.
Yes. So
that's something I sometimes see is the patients sort of think, oh, I'm taking it PRN for pain. Can you tell us how you manage that early NSAID instruction?
yes. If they don't have any contraindications such as renal impairment or, recent GI bleeds, I typically do ibuprofen 600 milligrams TID 3 times a day for that first 1 week, and then I check in with them, see how their symptoms are. Or if I'm checking inflammatory markers, I'll recheck and see if we're trending downwards back to normal before we start to taper off. Indomethacin, like I said, typically I'm using that as almost more of a second line if the ibuprofen isn't working. And so then I will do more of a 50 or 75 milligram dosing twice a day typically.
Anything else that you use? And I would say particularly, what if you call that patient at 2 weeks and they're still having pain? What do you tell them to do? I guess I'm getting at what percentage of patients have you found in this particular type of pericarditis that you need to resort to steroids? We know that they're not first line, but what's your trigger for putting them on steroids?
I would say that by and large, the majority of patients respond well to the initial treatment, and we don't need to do anything further after those first couple of weeks. I have had patients where when they finally come off the colchicine, they have a bit of a rebound. And I've had good luck with just putting them back on colchicine for another, for example, 3 months, so a total of 6 months. If after that couple of weeks, we're not seeing much improvement, honestly, I'm getting people such as yourself involved before we order those corticosteroids, just because they can just have that relapsing effect when we try and get patients off of those.
That's very helpful because it sounds like, for the most part, your initial approach is really effective in these patients.
Yes.
So Juan, I'm going to turn to you. What measures are surgeons taking that may prevent or reduce the incidence or the severity of this? Are there approaches that your teams are using or that others should be thinking about?
Well, that's a very important question. I mean, like everything, every type of disease that we take care of is better to prevent it than to treat it. And certainly the prevention starts during the surgery, and sometimes there's evidence that it can be started even before surgery by starting the administration of colchicine even before surgery. We don't do routinely that in our practice. However, at the time of the surgery, it's very important to have a strict hemostasis, making sure that the trauma to the pericardium the surgical trauma to the pericardium is minimized, and also making sure that there's no residual pericardial effusion. So the placement of the chest tubes and making sure that the pericardium is empty when the patient leaves the hospital is very important. And then in the postoperative period, prophylaxis with colchicine has also been demonstrated that it's effective in reducing the incidence of post pericardectomy syndrome.
Are there certain types of surgeries that you have started using routine postoperative colchicine because they're either you've seen it effective or there's evidence, or perhaps it's a particularly high risk for developing pericarditis?
In our practice, some of our colleagues used that routinely for aortic surgery and mitral surgery, as well as myxoma surgery, which has been anecdotal. There has been seen that there's a higher incidence. In particular, in my practice, where I do many of these patients who have carcinoid heart disease, those patients tend to develop post-pericardectomy syndrome and even constriction at a higher rate than other patients. And we have noticed that over the course of the years. And as a consequence of that, we place all these patients on colchicine post-operatively.
Is there anything that either one of you see as kind of the future? What should we be looking for in terms of any treatments or research that may be coming out on this condition?
I think that looking at our practice that I've been in for a little over 20 years now, I've seen much more emphasis on the prevention, which I think is exciting. And I think that's part of the reason that we don't see it, like you said, nearly as often as we used to. And I think going forward, especially with the work that was done on the COPS trials, they did 2 versions of that, looking at the effects of colchicine on the inflammatory process. And I suspect that we will be doing potentially at least afterwards prophylactic colchicine, and perhaps maybe prior to surgery starting it as well. What do you think, Dr. Crescenello?
Well, I think that the prophylaxis is very important. The routine use of colchicine has been shown that it's very effective, and then in terms of the treatment, is not clear the use of the new immunomodulators have in the management of this disease. Obviously, this is a different disease that patients that have idiopathic pericarditis, as well as the consideration of the use of immunomodulators immediately after surgery should be taken into account because of the risk associated with infections as well as wound healing.
Well, anything else you wanted to share today before we wrap up?
Well, I think that one of the things that is important is to consider a post-pericardectomy syndrome on patients who had persistent pain after cardiac surgery. But it's also important not to not to. It's important to keep in mind that there's other causes of chest pain. So if patient has a history of coronary artery disease, has coronary artery bypass grafting, or any there's other causes of pain immediately after the surgery that also should be ruled out and not attributed all the pain to post-pericardectomy syndrome.
Oh, that's such an important thing that we don't get focused in on perhaps the more common things, because obviously the history is critically important in knowing the patient. Well, thank you both.
Thanks for having us.
Thank you. Our pleasure.
This wraps up this week's episode of Interviews with the Experts. I'd like to thank you both for joining me today. We look forward to you joining us again next week for another interview with the expert. Be well.